But you look at the very next line of the question, a genetic predisposition in the form of HLA-DQ2. HLA-DQ2 positivity with a condition like diarrhea or malabsorption always points to the possibility of celiac disease. We all know that celiac disease is a type of gluten hypersensitivity where there is an allergic manifestation to gluten in the diet. So that is why the answer for this question has to be gluten-free diet. In fact, it is lifelong gluten-free diet which is advised for patients with celiac disease. Celiac disease is such an important topic. You should know some salient points about the same. As I said before, it is a gluten hypersensitivity and it is usually associated with exposure to foods which are remembered as bro. What is that? Barley, rye, oat, and wheat. And please remember that celiac disease results from the exposure to gluten in the diet as well as with genetic predisposition like HLA DQ2. This was given in the question. Another HLA association is HLA DQ8. Okay. And the diagnostic investigation for celiac disease is nothing but small intestinal biopsy, where you will see the characteristic features like atrophy of the villus along with increased space between the villi called as crypt hyperplasia. Along with that, inflammatory cells will be present in the intestinal villi. Okay, all these are characteristic in the small intestinal biopsy. And celiac disease is also characterized by the presence of antibodies, and the best antibody which can help in the diagnosis of celiac disease is anti-EMA antibody. What is EMA? It is anti-endomysial antibody, which is the best investigation among the antibodies in case of celiac disease. Moving on to the next question. A 11-year-old child had fever and sore throat 3 weeks back and now presents with fever, arthralgia and raised ESR. Heart evaluation is normal. How long should he receive penicillin prophylaxis? Please see this question. A typical age group, 11 years, something like a school-going child. Along with that, fever and sore throat history of 3 weeks back and now present with fever, arthralgia, raised ESR. What will you think of following a sore throat and now having fever and arthralgia? Yes, it's an acute rheumatic fever. Acute rheumatic fever. Fortunately, in this child, at present, the heart evaluation is normal. How long should he receive penicillin prophylaxis? We all know that acute rheumatic fever is a post-streptococcal condition, and future attacks of streptococcal infection again can precipitate an episode of rheumatic fever. But please remember, during recurrent attacks, heart is severely damaged. That is why always we need to give prophylaxis for these children with acute rheumatic fever to prevent any further attacks in future. Now the question is, how long should he receive prophylaxis? Please remember, the prophylaxis duration depends on the involvement of the heart. If there is no carditis, the prophylaxis is recommended for next 5 years or till the age of 18 years, whichever is longer. If the child has carditis, it is recommended for the next 10 years or till the age of 25 years, again, whichever is longer. Suppose the person has established RHD, that is rheumatic heart disease, or underwent a surgery like valve repair or replacement, ideally it is lifelong prophylaxis. Few texts will say that up to the age of 40 years it is recommended, but ideally it is lifelong prophylaxis which is recommended. Now coming back to the question, our question says that at present the heart evaluation is normal. That means he has no evidence of carditis. So what should be the answer? It should be for the next 5 years or till 18 years of age, whichever is longer. Option A is the correct answer. Regarding the drugs for prophylaxis, the commonly used drug is the penicillin, which is benzathine penicillin or penicillin G. It is usually given as an injection and the dose depends on the weight of the child. If the child is more than 30 kg, it is 12 lakh international units every 3 weeks. And if the child is less than 30 kg, it is 6 lakh international units every 2 weeks. As an alternative to the injectable penicillin, what we are using nowadays is oral penicillin V, which is usually given in the dose of 250 mg twice a day. Suppose the patient is allergic to penicillin, we will use erythromycin. Usually, erythromycin is given in the dose of again 250 mg twice a day. So these are the drugs for prophylaxis. Remember, the type of prophylaxis in acute rheumatic fever is secondary prophylaxis. The next question is about a 10-year-old child presenting with edema and massive proteinuria. A diagnosis of minimal change disease was made. Which of the following is true about this condition? Remember, edema, anasarca and massive proteinuria are all characteristic features of nephrotic syndrome, and in that the diagnosis itself is already given, which is minimal change disease. In fact, minimal change disease is the most common condition associated with nephrotic syndrome in children. The question is, which is true about this condition? Light microscopy shows effacement of podocyte. Remember, effacement of podocyte is a feature of minimal change disease. However, not on light microscopy you will be able to see. It would be seen only on electron microscopy. So that is not the answer. Next, good response to steroid. That is the answer for the question. In fact, all minimal change disease condition usually show an excellent response to steroids, and that is the answer for the question. Most common in adults? No, it is a type of nephrotic syndrome which is common in children. Non-selective proteinuria is again a wrong option because they have more of albumin excretion in the urine or more of a selective proteinuria. So all these are wrong options. The correct answer is option B. So nephrotic syndrome, according to the latest guidelines, the criteria is presence of significant proteinuria along with hypoalbuminemia or edema. Please remember, the criteria for significant proteinuria is more than 40 mg per meter square per hour of protein excretion in the urine. This is something which you should clearly know about. What is the criteria for nephrotic range proteinuria in children? That is also called as significant proteinuria. Okay, and as we discussed, the most common condition causing nephrotic syndrome is MCD, minimal change disease. Okay, please remember that minimal change disease is a diagnosis made pathologically, but clinically, how can we say that it is a case of minimal change disease? One is the age of the child. Typically, it occurs in the age group of 2 to 6 years. And second important hallmark feature is response to steroid. They show an excellent response to steroids. And the usual steroids which is used for this condition is prednisolone. And the duration of steroid treatment is 12 weeks. It is typically given as 6 weeks of daily steroids and 6 weeks of alternate day steroids. So that's about this particular question. Let's move on to the next question. A 5-year-old male child has difficulty in walking and getting up from a squatting position. Muscle biopsy was done and the picture is given. Which of the following is true about this particular condition? Remember, when the muscle biopsy picture is given and there is a difficulty in walking and a male child is given in the question, you always think about a muscle disorder, primarily a muscular dystrophy in children. Now, getting up from the squatting position, difficulty in getting up from the squatting position tells you that there is a proximal muscle weakness. We are talking about the proximal muscles in the hip region are having a weakness. Again, proximal muscle weakness is also a feature of muscular dystrophies or muscle disorders in children. Now let us look at the muscle biopsy finding. What you can see is that the size of the muscle fibers are not consistent. There is different shape of the muscle fibers which you can notice, and also there is evidence of these necrotic muscle fibers. Along with that, you can also see the connective tissue in between the muscle fibers is increased. What we call it as endomysial connective tissue proliferation is noted. And these are all very classical findings of the most common muscular dystrophy, which is DMD. What is that? It is Duchenne muscular dystrophy. And that is the diagnosis for this particular question. So let us look at the options related to this question. Death occurs by third decade. Is it true? That is the correct statement about Duchenne muscular dystrophy? And the answer for this question, usually Duchenne muscular dystrophy patient, when they become teenagers or by 20 to 29 years or around that third decade, they usually die. And that's a true statement. Previous history of viral prodrome is present? Not at all. It is not a post-viral condition and all, so that option is wrong. It's a mitochondrial storage disorder? No, it's a muscular dystrophy disorder. It's an inherited condition, so it's not a mitochondrial storage disorder. Early treatment has excellent prognosis? Not at all. It is not a curable condition. Even though steroids are found to decrease the progression of the disease, still it is a progressive disease and finally causes death. And no treatment is curative for this particular condition. So that is also a wrong option. So the answer is option A. Now please remember, these are the texts which are taken from Nelson textbook of pediatrics, where it clearly mentioned that death in boys with Duchenne muscular dystrophy occurs in the late teens to 20s. That means in the third decade, they usually die. And the cause of death is a combination of respiratory problems like respiratory failure, as well as cardiac problems like intractable heart failure. These are the two usual conditions associated with death in a child with Duchenne muscular dystrophy. To explain that findings only, I'll do that again, okay? To explain the findings in Duchenne muscular dystrophy, this muscle biopsy picture is taken. The first is a normal muscle biopsy picture where you can see a consistent size of the muscle fibers. Whereas the next picture is for DMD or Duchenne muscular dystrophy, where you can see irregular shape of the muscle fibers, and also you can see evidence of necrosis happening in the muscle fibers. These are all very, very characteristic of Duchenne muscular dystrophy on the muscle biopsy. DMD as such is the most common hereditary neuromuscular disorder, and the most common mode of inheritance is X-linked recessive mode of inheritance. Okay, right? And the basic defect is in the dystrophin gene defect. Please remember, the characteristic type of dystrophin gene defect is a frame shift mutation. The characteristic features, clinical features of Duchenne muscular dystrophy is 1. Proximal muscle weakness. And because of the proximal muscle weakness, they have delayed walking. They have this characteristic waddling gait, as well as they have the positive Gover sign, okay, which is a sign elicited on asking the patient with Duchenne muscular dystrophy to get up from the sitting position. Okay, please remember, Gover sign is not diagnostic of Duchenne muscular dystrophy. In any condition where you have proximal muscle weakness, like in juvenile dermatomyositis, there also you have proximal muscle weakness, and there also Gover sign is positive. And third important feature is pseudohypertrophy. This pseudohypertrophy is due to deposition of fibrous tissue and fatty tissue in the region of calf muscle area. So pseudohypertrophy characteristically noted in the calf muscles is again a characteristic finding in case of Duchenne muscular dystrophy. And finally, what happened? They will have progressive muscular problems leading to loss of ambulation around the age of 10 to 14 years. Or in other words, around the age of 10 to 14 years, they become wheelchair dependent. These are the characteristic features of Duchenne muscular dystrophy that one should know about. The next question, an 8-year-old male child presented with palpable purpura over the lower limbs and also complaints of arthralgia and abdominal pain. There was a preceding history of upper respiratory infection. Which of the following drug is useful in the management? Please remember that when you have a child presenting with a classical description of palpable purpura, abdominal pain, as well as joint pain or arthralgia, you should strongly consider the possibility of HSP, Henoch-Schondlin purpura, which is IgA vasculitis. It is one of the common vasculitis in childhood, and it is a small vessel vasculitis. Now this question is about drug useful in the treatment of Henoch-Schondlin purpura. When you talk about Henoch-Schondlin purpura treatment, remember, most cases are self-limiting, and all that is required is supportive treatment. Supportive treatment usually includes good nutrition, good hydration, as well as pain relief with analgesics. That is all that is required for the management of HSP. However, if a drug is going to be helpful, the commonly used drug is a steroid. And the role of steroid is not for all cases, only if there is a significant gastrointestinal involvement or any life-threatening manifestation, then you are supposed to use the steroid. So suppose child presents with intractable abdominal pain or other GI manifestations which is very severe, then you can use steroids. Also, steroids can also reduce the intensity of abdominal and joint pain. So again, severe manifestations of disease only requires the use of steroid. In this particular question, you can see 4 options given. Out of that, steroids are the ones which can be helpful in the usual management. And don't forget, only in severe cases of HSP, steroids are required in the management. This is the diagnostic criteria for Henoch-Schönlein purpura. Please remember that the most essential criteria is palpable purpura. Usually palpable purpura is noted in the lower limbs, and the reason for purpura is vasculitis and not thrombocytopenia. Or in other words, the platelet count is normal in case of Henoch-Schönlein purpura. This is a very essential part of diagnosis, presence of palpable purpura. Along with that, you should have one or more of the following manifestations, which include abdominal pain, which is a type of diffuse acute colicky pain in the abdomen, and usually it is after food intake or postprandial abdominal pain. Next, they can have arthritis or arthralgia. Third, biopsy. Usually the skin biopsy is taken and biopsy demonstrates IgA deposition. And finally, some cases can also have renal involvement in the form of proteinuria, hematuria or red cell cast. Please remember, palpable purpura along with any one of the other 4 features would be making to the criteria of Henoch-Schönlein purpura. So that is about the discussion of this question, and with that I am ending the discussion of NEET PG 2022 questions asked in the section of pediatrics. Thank you.